The infections occurred later in the everolimus group, and there was a trend towards a lower recurrence rate. But still, this data suggests that this specific group might still be a group for CMV prophylaxis, or at least a very strict preemptive therapy. This is a study from France, and they looked at an interesting aspect because they looked at the patients in the sense of what happens to them. How is the CMV infection rate after withdrawal of the prophylaxis? Remember, at one time we do have to withdraw the prophylaxis, at least in the high-risk patients that we give prophylaxis to, at 90 days, at 180 days, but at some time point they have, by withdrawal of the prophylaxis, a certain increase of the risk of infection. And they looked at 215 patients, either basiliximab, CNI, and steroids, with everolimus or MPA, 97 in the everolimus group, 118 in the MPA group, and valganciclovir was given according to the recipient's serostatus, 400 milligrams per day, which is a relatively low dose for, at least for recipients who have a very good graft function. They gave for 6 months in the donor-positive, recipient-negative group, and in the intermediate risk groups, they gave for 3 months. This was the serostatus at the beginning of the study. So what you would expect is that around between 40-45% in the D plus R plus group, another 20 to 26% in the D minus R plus group, and between 15 and 20% in the high risk group. So no significant differences between the two groups. However, after withdrawal of the prophylaxis, they looked at the first CMV disease in those patients between the two study groups, and they saw that the incidence was significantly lower in those patients who received everolimus and who had the high-risk serostatus. So although they needed to give prophylaxis for a certain time, 6 months in this case, they saw a positive influence on the recurrence rate, and this is quite significant and quite impressive. So maybe you cannot do it without any prophylaxis, but at least once you've withdrawn the prophylaxis, you can relax a little more. This is again a study from Brazil, and they looked at the influence of ATG on the CMV viral load. All those patients were CMV seropositive. The recipients were seropositive, and they received ATG tacrolimus, everolimus, or basiliximab tacrolimus, everolimus, or basiliximab tacrolimus, and mycophenolate. Between 80 and 100 patients in each group. They looked at antigenemia, and what they saw is in the ATG tacrolimus everolimus group, they saw an incidence of this is CMV. They said CMV freedom of CMV negative 23% or 75% positive, and this is the same as they saw in the basiliximab tacrolimus MPA group, same percentage. In the basiliximab tacrolimus everolimus group, more than half the patients were free. So this was an interesting finding. Apparently in this group, the addition of ATG does not comprise an additional risk compared with this group, and interestingly, the number of copies was lower in this group compared with this one. This is what we do in our center. Actually, we stopped to do CMV prophylaxis in what we call the intermediate risk group. Those would be those patients who received ATG or thymoglobulin induction. Until 2011, we gave a short prophylaxis for 4 weeks in those patients, and after that, in combination with the mTOR inhibitor, we've done only preemptive therapy, whereas the high-risk group receives valganciclovir between before 2011 and also after 2011, and the low risk group, they only receive preemptive therapy. So excluding the high risk group and take into consideration all receive ATG, all receive tacrolimus, all receive an mTOR inhibitor, and we compare the no prophylaxis group with in red and with the CMV prophylaxis group and the percentage of freedom of CMV, and we see that during the first year there is no difference between the two groups. So in the intermediate group, we actually use the everolimus treatment as CMV prophylaxis. There's one thing that you have to think about. If for some reason you need to withdraw the everolimus therapy, then you might have an increased risk of CMV infection in those patients. Again, high-risk patients censored, all receive ATG, all receive everolimus, and for side effects, everolimus was withdrawn in those patients. There was a 29% risk of CMV infection compared with those who remained on therapy, 5%. So if for some reason you need to withdraw the everolimus, think of evaluating if this patient needs a more intensive monitorization or prophylaxis. There are some hypotheses about the molecular mechanisms of the mTOR inhibitors against the cytomegalovirus. In terms of the host cell, the mTOR inhibition might have a positive influence on the host cell's defense, or might on the host cells, on the viral development in the host cell, and also on the viral defense in the CD8 positive T cells. And this group, they looked at those mechanisms a little more in detail. They chose CMV IgG positive patients, all received prednisone, cyclosporin, MPS for the first 6 months, and then they were switched to some kind of double therapy, either prednisone everolimus or prednisone cyclosporin or prednisone and MPS. And then they looked at the CMV-specific CD8 T cells, and they saw that after the withdrawal of, after initiating double therapy in that group that received prednisone everolimus, there was a significant increase of the CMV-specific CD8 positive T cells, which did not occur in the other two groups. So this seems to be a clear everolimus-associated effect. Now let's switch to BK virus infections. We know that BK virus infections are relatively frequent according to the immunosuppressive regimen. In the last talk, we saw that those patients, ABO-incompatible patients who risk of graft loss in those cases. This is This is further looked at in a study from Berlin, and they looked at B virus replication following transplantation and looked at the immunosuppressive regimen, thymoglobulin induction, and regimens involving tacrolimus and mycophenolate, or this is a bad combination for the development of BK virus infection and BK virus nephropathy. And they postulate that it is justified that an early modification of the intensity and age of the immunosuppression can actually help to control the BK virus nephropathy problem. This is, again, a registry study and clear association with the immunosuppression, thymoglobulin, and tacrolimus. And if there is an mTOR inhibitor in the treatment, then there is a significantly lower risk. This is again this study from Berlin, and they looked at those patients with calcineurin inhibitor, MMF, or MPA, and steroids, and prospectively looked for BK viremia, and they did protocol biopsies, and they saw that they looked at BK viremia and also BK or polyomavirus nephropathy in those patients, and found differences between the different patients. Not all viremias, of course, led to BK virus nephropathy, but high percentage of viremic patients also presented with BK virus nephropathy. So again, that's bad news. And they also saw that the switch of immunosuppression to a low-dose cyclosporin plus mTOR inhibitor, switch from tacrolimus plus mycophenolate, was safe, was well tolerated, and tended to be associated with a better short-term outcome compared with just reduction of existing immunosuppression alone. This is also a study from Germany, from ANOVA, and they looked at the different factors that influence the viral cleaning and the renal function during BK virus-associated nephropathy, and the peak viral load at diagnosis, treatment with tacrolimus, the delayed diagnosis, and the time until virus reduction have a negative influence on the outcome. So especially here, I think we can intervene. We have to try to achieve a virus reduction in a relatively short time. And they also conclude that a switch from a CNI to an mTOR inhibitor is beneficial regarding the viral reduction. So this is the 2309 study, cyclosporin in combination with steroids and either everolimus or MPS. And again, we see that also with the combination of this calcineurin inhibitor and the everolimus, we get a lower incidence of BK virus infections. And in the transform study, so similar but mostly with tacrolimus, we also see that there is a lower incidence of BK virus infections in those patients with everolimus, 50% of what the incidence was in the MPA study group. So we can conclude that viral infections negatively influence kidney transplant outcomes. Their incidence depends on serostatus and on the immunosuppressive protocols. There are less CMV infections and less BK virus infections under mTOR inhibitor treatment. mTOR inhibitors show, apart from the immunosuppressive effect, some antipathogenic mechanisms against CMV, against the BK virus. We have not talked about oncogenic virus, but for those viruses it's true as well. And interestingly, at least in vitro, it's also true for Candida infections, and can thus improve kidney transplant outcomes in multiple ways. It is important, and we probably need more studies and more experimental studies in that way to understand the mTOR mechanisms, and this enables us to use mTOR inhibitors as prevention of CMV and BK virus infections without necessarily compromising the immunosuppressive potency of that regimen. With that, I would like to thank you very much for your attention, and I'm happy to take questions.
Yes, with the mic.
Good evening. It's Dr. Usman Khalid Chima. I just want to ask your experience regarding the treatment of CME at your center. On one hand, and on second hand, any experience and how you monitor and what are the duration of treatment in CME? And any experience regarding that recurrence of CME post-transplant again and again in single patient?
If I really understood the question.
What are the strategies to treat CME at your center? Duration and monitoring of CME, and then on the other hand, on single patient, have you any experience on CME infection again and again? What to do in that case?
So what is the monitoring? How do we monitor?
Yeah.
Okay, so what we do is we do only in the high-risk patients, D positive, receptor negative. We do prophylaxis for 3 months, and all the other patients we do what I would call a modified preemptive therapy, because we do not check PCR every week, but we do check PCR basically every 2 weeks during the first 3 months. And if the PCR is positive, and positive is in our center basically anything above the detection level, then we would start treatment with valganciclovir.
For how many weeks or days?
Then we do valganciclovir treatment until we have at least one negative determination of the PCR, and then we would start over again. Then we'd switch to preemptive therapy again.
Okay. Then the duration of preemptive therapy is like 48 days or like what, roughly? Well, I just want to ask one question, because I am having a problem on one patient, and her PCR was negative for twice, like she was treated for 98 days. After 6 weeks, again she was symptomatic and her PCR was positive. What to do in that case?
Well, this is quite a common phenomenon. You have replication, you do treatment, you stop treatment, and then at some time you kind of even detect more an episode of replication again. What usually happens is that your curves are high, then it goes lower and lower again. So we switch back after treatment. We switch back to preemptive therapy again, and we treat usually after. If you have one relapse, then usually you've got it controlled. But and we have very few cases with viral resistance, for example, which happens probably less than once a year in our center.
Thank you so much, sir. Thank you, sir, Dr. Fritz. Now we move to the last speaker, Dr. Frederick, the optimizing the use of mycophenolate in renal transplantation.
So thank you very much, and thank you for all of you that are resisting until the end of the session. I will try to be quite fast. So, as you well know, we have two formulations of mycophenolic acid. We have the mycophenolic mofetil and the mycophenolic sodium. This is an ester. This is a product that needs to be de-esterized. This is a salt. This needs only to dissolve, and this is the major difference between these two drugs. And the mechanism of action is the inhibition of the inosine monophosphate dehydrogenase that blocks the de novo pathway. This is particularly important in the lymphocytes because they depend only on this pathway to synthesize DNA, and this is the main difference between the lymphocytes and the other and other cells. So the mycophenolic acid is blocking the AMPDH enzyme. The other important point is the pharmacokinetics of the drug. The mycophenolic mofetil is absorbed very fast in the stomach, then it hydrolyzes and became mycophenolic acid, the active compound. The mycophenolic sodium is absorbed in the intestine and also released as mycophenolic acid. The majority of the drug is excreted in the urine as a metabolite, and also part of the mycophenolic acid is deglucuronized and excreted in the bile, and then there is started a enterohepatic recirculation. This is important factor because the differences between cyclosporin and tacrolimus in terms of blocking the enterohepatic recirculation. The other point is the absorption that is seen when you will perform an AUC curve and you compare cyclosporin and tacrolimus. You see that at the same dose, the tacrolimus is absorbed much higher than the cyclosporin, and this also have consequences in terms of managing the drug. When the majority of this compound, the mycophenolic acid, is bound to the proteins, to the albumin, and this is how the proportion of unbound and bound mycophenolic acid in a normal physiology situation. This is what it happens in a patient with hypoalbuminemia, that the bound fraction decreases, and the unbound remains stable. This is what it happens with a patient with decreased GFR and with an enterohepatic cycle inhibition. For example, a patient with chronic renal graft failure, transplant failure, that is treated with cyclosporin. Here you see a decrease in the bound fraction and an increase in the unbound fraction. And this is what it happens in a patient that has also a transplant with a chronic renal failure, but is treated with tacrolimus, for example. Then here the enterohepatic cycle is not inhibited, and then here you see that increases both the unbound and the bound fraction, and the total exposure increases. So this is important in order to manage the dose of these drugs in patients transplanted that have chronic rejection, for example. So mycophenolic acid was introduced in transplantation, comparing its effect against rejection versus azathoprine or a placebo. There were 3 main studies. This is the 3-continental study, and in this study, both the 2 grams and the 3 grams arms of the study were better than the AZA in terms of rejection protection, especially the 2 grams. But this was more clear in the study against a placebo. That finally the conclusion of these 3 studies was that the 2 grams a day in combination with cyclosporin is the best solution, a fixed dose. Not need of trough levels or therapeutic drug monitoring. However, we know that there is an effect of the mycophenolic exposure and the probability of rejection. And when we establish the AUC above which is the effect of the protection against rejection, we established that it is between 20 and 80, and probably above 30 is enough to protect during the postoperative period. This is a study analyzing 2 groups of patients, one treated with fixed dose of mycophenolic acid, and the other one with adjusting the dose according to the AUCs. And you see that the rejection rates decreases from 24% to 7% in those patients that were treated with adjusted doses according to the early AUC. This is another very interesting study from Van Helder, again using concentration controlled doses of mycophenolic acid, and when he compares those AUCs at day 3 post-transplantation, they were below or above 30, that this is the low level of the AUC that they establish as a requirement. They see a significantly increase in the rejection rate for those patients that at grade 3 were with an AUC below 30. The problem is that day 3, you have an AUC that is based on what you are giving at the beginning, because you have no time to manage any kind of dose at day 3. So the question is necessary or not to perform TDM adjustments in MMF patients, as what was not established in the studies. That the question is, using fixed dose would be enough. So from this review of experts, they concluded that only in specific situations or specific patients with absorption problems, patients where you are needing to reduce very much immunosuppressions or make a change, or with gastrointestinal problems, etc. In these cases, may be interesting to perform TDM, but not in the general population at all. The other strategy could be, because if the most important is that on day 3 achieve this high AUC, is to start with higher doses and then reduce the dose. And this is what was done in this German study, that they were using mycophenolate sodium, and they started with 2,880 milligrams. This is the equivalent to 4 grams of MMF during 2 weeks. Then they reduced it to 2,160, that is like 3 grams, and after